Thank you each for your presentations, very helpful. Before I open up the panel to questions, I'm going to try to frame this a little bit more by asking each of the panelists a question about how their organization could help, or their experience of their organization could help in this new landscape of CCBHCs. To be honest, this is sort of a terra incognita. As Steve Rosenberg says, we're building the plane while it's flying, especially in this planning year. And so, Dina, starting with you, you're sort of, SAMHSA's very involved in setting up the guidelines, but it's also has lots of experience with interoperability, and also how can this experience assist CCBHCs meet the health IT requirements that they're going to face in the near future?
Well, I want to pick up, I think, where Karen talked about with 42 CFR, because I know that's part two is on a lot of people's minds, and we've done a lot of work around data segmentation for privacy in order to help support privacy and security. And I mentioned previously a piece of software that we developed is called Consent to Share, and it's built on the data segmentation for privacy standard. It's software that can be deployed by an HIE, by an individual provider, so on all sort of levels of the electronic care continuum in order to capture patient consent, segment, tag data, segment data, and then only share the part of the record that the patient has consented to share, and share it with all of the redisclosure and 42 CFR warnings or whatever language on the data. So we've done that work. We worked with Prince George's County in Maryland in order to pilot it, and they've continued to use Consent to Share in their work. We recently did a pilot with the Michiana Health Information Network and 2 opioid treatment programs in New York City in order to share data between those 2 OTPs, and they used a Cerner as their vendor and NetSmart in order to also use data segmentation for privacy to make this work. So we continue to work on software, and we offer that to any of the CCBHCs or anyone else out there who is looking for implementing data segmentation for privacy. And we also have technical assistance that we can provide. So I would say in that regard, we've been very active in helping to get the infrastructure in place for safe sharing of data across providers.
What I've heard you say, which is really important, is when you think of data segmentation, you think of structured data, because you already have the structured data, and then you put a structure over it. And I just would like to reemphasize that as a provider type, CCBHCs need to have structured data. And what's really important for people to hear, and especially the people I want to hear this, is vendors. And this is what the CCBHCs are going to have to understand when they purchase products, is that the data is structured, because without that structured data, we won't be able to have clinical quality improvements, which the enhanced payments are based off of. And so this is really quite important, the work that SAMHSA is doing in this area. I'd like to now turn to you, Kamala. You just can't put a piece of software on somebody's desk and say, okay, this is going to meet all the requirements of your job, without knowing the business, the actual business of what's going on. And I think where Urban is extraordinarily valuable in this is your project with BJA, with your justice reinvestment, where The complication with CCBHCs is you're dealing with multiple organizations. And so could you speak to your work of working with multi-stakeholders and how that could be important for CCBHCs?
Sure. I would encourage the CCBHCs to think about what they need to know from the justice system. What are the pieces of information that would help them to serve their clients better and then engage with those parts of the criminal justice system. So bringing people to the table to find out what are the shared pieces of information that they have, the extent to which they share the client base, and then to really start digging in to figure out what their consent landscape is. There are, I'm sure, opportunities there to develop uniform consent forms like what Kentucky has done. But it is going to be a different situation in every state and sometimes every locality depending on what the regulatory environment is. So I think that that process of reaching out and really defining what these terms of sharing can be is a critical first step.
Karen, I have a bias. I love implementers, being a software engineer, because you understand how difficult this task can be. I don't want to pour cold water on it. What I want to do is say it can be done, but it's difficult. Could you, when I was talking to one of your colleagues, Polly Bentley Mullins, from the KHIE, and she was talking to me, the whole process of getting CCDs from behavioral health organizations and getting that to work with KHIE. Could you go into a little bit more detail, the time span, how you had to work with different stakeholders in Kentucky to get this, to achieve this remarkable feat?
Well, the thing that we first thought, that the consent form was going to be the most difficult thing for us to achieve. But in essence, with the support of the grant funding and the process that we worked through with the grant funding, having in our state, having SAMHSA and the National Council standing behind us, once we had that credibility of the work product that came out of that grant funding, that became an easy step once we had that work product. We took it to our stakeholders, and really there was no pushback about that at all. When we first approached the product, we thought the technology was going to be the easier jump. Little did we know. Then it became that the hard coding that I talked about. We thought to begin with that just that simple hard coding. But when you start talking about across your HIE, and you can stand up here and you can say, oh, well, we're just going to pull a CCD in and it's going to say that. Well, what you forget about that is the way Kentucky's implementation is when you pull that CCD in, what that means is it comes into a provider's electronic medical record. And when that comes in, the provider then has control over it. So they bring it in on their template. Well, that non-disclosure language, to comply with the federal regulation, has to be across the top of that CCD if it comes in from a community mental health center in the state of Kentucky. That's what we call them in the state of Kentucky. So if it doesn't have that, we're not in compliance. So we had already onboarded our providers that were going to pull that CCD in, have that connectivity. So then it was a matter of, we're going back and saying to them, oh, wait a minute. Now we're going to have to onboard you again. You're going to have to commit that your template is going to display this. So it became It became a redo. So that takes leadership. That takes your leadership saying, is this a priority? Well, the thing to remember is in Kentucky, it is a priority. Behavioral health is not an afterthought. It is there at the beginning. We are housed in the Cabinet for Health and Family Services. The Cabinet for Health and Family Services owns the state inpatient psychiatric hospitals. The Cabinet for Health and Family Services provides financing, provides financial resources for the 14 community mental health centers. So it's a huge priority. But if you don't have that kind of leadership, we could have really got totally derailed right at that point.
Thank you, thank you. I'd just like to repeat before I open this up to questions I think it's really essential to know at this moment that none of us are experts in CCBHC-IT. We're sort of trying to get ready and understand this world, and so come back maybe in 2 or 3 years on this stage when we're all experts on CCBHCs and we'll answer the real nitty-gritty questions. But with that said, I'd like to open up the panel to questions.
As long as nobody's knocking down the door to raise their hand, I'll make a comment. And if you don't like this comment, you can blame Steve Rosenberg standing over there holding his...
It's a good person to blame.
It's the safest person to blame. So it's a word of caution about electronic health records. And the word of caution is, and I can't remember who said this, but you can't have interoperability without operability. I look at hundreds of electronic medical records in jails and prisons. Most of them are not well designed and do not provide good patient care. Now, let me phrase that a little bit more carefully. There are challenges to patient care with most of the electronic medical records that I read, both patient care and subsequent use of the record by others. There are nonsense terms in the middle of medical records that the computer puts in there. I love electronic medical records. We're going in that direction. We have to. But at the same time, we have to remember about the operability of the records. The literature does not show very, very strong evidence for improved patient care with electronic medical records. In the few places where it does work, if you export that functionality to another place, you may find it doesn't work well because it worked well in that context, in that setting, but not in another. So I guess I caution us all when we're talking about the operability of a medical record and also interoperability to make sure that patient care benefits from the implementation of a medical record and benefits from the implementation of an interoperability between medical records. And now, Steve.
I think those are great points, Mark, and I just want to frame them in how I introduce this panel. I think what we've heard up until this panel is how everyone agrees that we have this challenge of behavioral health and criminal justice, that CCBHCs represent a way that we can ameliorate some of that and move us forward into ending mass incarceration. As Ben said when he started off this panel, one of the requirements of CCBHCs is that they have structured data and electronic medical records. It's not open for debate. It's a requirement of the CCBHC. And I think what you're hopefully hearing, and I think, Mark, part of what you're saying is a little bit of we need to make sure that we do this well in terms of being quality patient care. Hopefully what you've heard from the panel are all of the challenges of doing this. I think what I really want to make sure that you hear, and part of why we wanted to have this panel, is for you all to understand what a steep hill CCBHCs have to climb, okay, and the very short time frame they have to climb it in. So this is part of our goal, part of Cochs' goal in partnering with the National Council in having this conference, was to have you hear from a senator, from the acting administrator of SAMHSA, and from the White House about how we have consensus that this is a road we want to figure out how to travel down, okay? And in trying to figure out how we travel down this road, it's going to have bumps, it's going to be steep, and it's going to be challenging. But on the other hand, what I would argue is we don't have a choice. that as a society we have decided that we are going to end the epidemic of mass incarceration, and that CCBHCs have to be an integral part of that. Ben? And I'm giving you back your microphone.
Thank you.
Hello, I'd like to know if we anticipate any additional certification processes for electronic health records in order to be used by the CCBHC that is coming, similar to the 2014 certification standards that we got through meaningful use.
I know that issue's meaningful use for behavioral health has been discussed up on the Hill. I don't know where that stands at this point in time.
And I'm wondering if, and you guys might not be, you're the last panel, so you get the question whether you're the right panel or not. Whether there will be performance metrics in the CCBHCs that tie to criminal justice involvement and any sort of reduction in involvement or cycling through jails. You said, Steve, that we're looking at behavioral health care as a significant support to ending mass incarceration and the criminalization of people with behavioral health conditions. Unless we have metrics that tie those two things together, I don't think they will logically stay connected.
One of the unique things about the CCBHC program, Pam, is that each state is going to have to decide how they're going to certify CCBHCs and what issues the state will believe will be important in ensuring that CCBHCs increase access and increase quality. So I would say one of the jobs of folks in this room, going back to things that we take home from us and Roy's message, is to make sure that you have conversations within your state about how the CCBHC can interact with this and suggest performance metrics, if that's appropriate. I think Richard Chiola talked before about the role of plans, and as plans start getting more and more involved in this, and plans have an embedded role within the CCBHC design, that plans themselves will start looking for performance indicators in terms of managing high-risk, high-cost patients. Well, guess who high-risk, high-cost patients are? They circle in and out of the justice system. So I think, to answer your question, not yet, but it will be a combination of market forces that come from plans and states as they think through the process of what does the CCBHC do across all budget lines in the state. So that would be my answer. I don't know that SAMHSA has yet defined what kinds of program indicators it will put on states. I think that there are evaluation metrics that they'll have to report, but I don't think yet there will be what I would call contingencies, which is what I hear your question to be. I think that this is still a work in progress. And David and Cindy, are you still here? Yeah. So those are the folks you want to talk to. Want to raise your hand, David and Cindy? Yeah.
We have 32 quality measures. They're in the criteria that each of the states are going to have to report on. Anything else? Oh, I should say, none of those are specific to criminal justice. So they're just outcome and process measures in general.
We have time for one more question, then?
I'm interested in K-High a little bit more. Did you mandate all provider participation in the K-High system?
When we first started, we were more driven by meaningful use because we are the state-identified public health entity. But the longer that we have been in existence, criminal justice came knocking on our door. behavioral health, much the same issue. Our community mental health centers, the same response. Some of it because we are the public health, some of that has been driven by mental or by meaningful use, but now it is more coordination of care, especially within the cabinet. And our cabinet agencies, because of integration of care, we have a complete Medicaid claims database. So if you have any Medicaid users, and those are specifically with our psychiatric hospitals, with many of our Medicaid users, they want that data feed so they can see what is in there, and that's what's driving our use right now and our providers within that use.
I think that Kentucky really should be commended for the tremendous work it's done. I've been following it for a number of years, and it is truly impressive.
Thank you. We appreciate it so much.
Thank you all.